Fighting malaria, a new vaccine is tested and is partly effective. For many, it's a glimmer of hope that the disease that kills thousands every year could finally be eradicated. But why has it taken so long to get this far? This is Inside Story. Hello and welcome to the programme. I'm Martine Dennis. Now, scientists call it a very clever parasite, and it's roamed the earth, spreading death and infection for centuries. But now, researchers are one step closer to finally eradicating it. The world's first malaria vaccine could be on the market within months. And despite its modest 30% success rate, the development is being hailed as a huge success. Now, if RTS is approved, it'll be the first ever licensed human vaccine against a parasitic disease. Now, malaria is most prevalent in sub-Saharan Africa, where nearly all of the 600,000 deaths in 2013 occurred. The vast majority of them were children younger than 5. And to make matters worse, last year's Ebola epidemic disrupted malaria prevention and treatment programs, leading to more than 3.5 million additional cases of the disease. But beyond the human suffering, malaria is a significant drag on struggling African economies. Developmental economist Jeffrey Sachs estimated that malaria knocks out around 18% of the worst affected countries' national incomes. Well, this vaccine is a result of more than 30 years of research. Malaria has proven to be a particularly pesky parasite because of its complicated life cycle and its ability to adapt. But even so, many say the fight against malaria should be much further along, or even that the battle should be won by now. Exactly 15 years ago, African leaders met at a World Health Organization summit in the Nigerian capital, Abuja, and they called it Rollback Malaria. They planned to reduce the number of malaria deaths in Africa to 250,000 by the end of this year, distribute mosquito nets for full coverage in regions susceptible to malaria, and increase funding for malaria research. But none of those goals have actually been met, which raises the question, what's holding them back? We can hear from our guests now. From Oxford, we can talk to Professor Adrian Hill, who is director of the Jenner Institute at Oxford University, where he specialises in human genetics. And joining me here in the studio is Dr. Riaz Malik, Professor of Medicine at the Weill Cornell Medical College, that's here in Doha. And also joining us via Skype from the island of Paros in Greece is Dr. Vasi Murthy from WHO, the World Health Organization. Well, welcome to you all. Can I start with you, Professor Hill, in Oxford? First of all, your assessment of this step in the path to eradicating malaria. How significant is this stage towards a vaccine?
This is a hugely important trial. It ran for 5 years. It cost hundreds of millions of dollars. It involved almost 16,000 babies and children in sub-Saharan Africa. And today we have the final results. We've seen 3 earlier reports on this trial, so the results aren't a big surprise. The vaccine works quite well for some months, but over years its efficacy fades and wanes, and we even now see some evidence that there's a rebound, in other words, more malaria in the vaccinees towards the end of the follow-up period.
So it's unlikely then...
The efficacy of the vaccine is...
It's unlikely then that this is going to be rolled out?
I think that's a very difficult judgment to make, and we don't know the answer. We don't even know if this vaccine will be licensed. And if it's not licensed, it can't be rolled out. That review has been going on for well over a year. But what we do know now is that we see different levels of efficacy in different age groups. Unfortunately, the age group we regularly vaccinate, the young infants, shows low efficacy of the order of 18% compared to 28% in the older children of 5 to 17 months when they're first vaccinated. And we also have a worry now that the efficacy against severe forms of malaria isn't as good as against malaria episodes, and certainly the data suggests that. And unfortunately, it's the severe malaria and death that we really want to prevent with a vaccine.
OK, going to Dr. Vasi Murthy now in Paros. You work for WHO, and the rates of infection and the rates of death have reduced significantly since that rollback malaria campaign was launched back in 2000. So is a very costly vaccine actually necessary?
Thank you. Well, first of all, I'd like to compliment the Vaccine Development Partnership, which is responsible for conducting this trial. I think we should acknowledge that it is a success story getting to this point. This is the largest ever malaria vaccine trial which has occurred in history, successfully conducted to a very high quality. So this is a public-private partnership between GlaxoSmithKline and PATH with funds from the Bill and Melinda Gates Foundation. And another important advantage of the whole approach that's been taken is that 11 clinical research centres in Africa have come together working in 7 countries to provide these results. So I think we should all applaud the quality of the research that's been done. I think what's being asked now is what are the next steps, and as Professor Hill mentioned, there are the normal steps that follow at this point with new vaccine development. So the results are now being announced by the scientists that conducted the research. The next steps are that the regulatory authorities need to give their assessment. So this remains an experimental product.
OK,
so,
but as I go back to my question, and that is that the direction of travel in terms of the rates of infection, in terms of the rates of deaths, is going in the right way. So is this absolutely necessary?
So I think that's a good question. The important point is that should this vaccine get to the point of being used, it is not a replacement for any of the core WHO recommended malaria control measures. So the core, and these have all been working well, but we need more investments so that we can go further with these. So this is long-lasting insecticide-treated bed nets, which have been rolled out in the hundreds of millions over the last 15 years. And we know that these save lives. This is prompt diagnosis so that we can direct the drugs to the children that have malaria. And this is access to effective drugs. Now, all of these have been ramped up massively over the last 15 years. And the big reduction, and as you say, this is a success story. The big reduction, roughly a halving of the malaria deaths per year from over 1 million to less than 500,000 children in Africa dying a year. This has all been associated with this scale-up.
Dr. Riaz Malik now here in the studio with me. There is a school of thought that suggests, of course, that there's been some kind of collusion, if you like, among the big pharmaceutical giants who are essentially profit-driven, not to apply themselves terribly much to this particular problem, because it does affect poor Africans and there's not much money to be made from them.
I think there's an element of truth there, but it's not wholly true, because obviously GSK have invested a huge amount of money to bring the trial to fruition as we've seen it at the moment. Yes, if malaria had affected the US or the UK or Europe, we would have likely seen much faster progress in terms of more trials, more investment, and that's where we are.
And Adrian Hill in Oxford, how many of the weapons do we have in the armoury to actually defeat malaria, to eliminate it completely? Because, as I said before, it has been done in many parts of the world.
So as Dr. Murthy said, today many of those tools are being used and used very effectively, particularly insecticide impregnated bed nets, which have pretty useful efficacy in reducing malaria mortality, and we're seeing those being used more and more widely in Africa, which is excellent, and that must continue. We've had spraying for many years. We now have better combination drugs, so we need to keep using all of those tools. And of course those tools work best where malaria transmission is weak or light. And that's why we were able to eradicate malaria from Europe, because the intensity of transmission in Europe is a small fraction of that in Central Africa. So it's really for these hotbeds of malaria where there's a lot of transmission, where existing tools are still not preventing those 500,000 deaths, that we need a new vaccine. And of course, My view, and I think that of many people, is that a highly effective vaccine with good durability would be the best new tool for controlling and then eventually eradicating malaria.
And Dr. Morthy, given that, how far away are we from this ultimate objective of eradicating the disease?
So the World Health Organization has developed a global technical strategy for malaria control from 2016 to 2030, and that sets out very ambitious targets. The aim there is to have over 30 additional countries by the end of that time frame that have achieved malaria elimination. So by elimination, we mean at the country level. Global eradication is an aspiration that we all very much are working towards. That is going to take a little longer, and this is partly because, as Professor Hill said, even with the same tools, one can eliminate in some settings and cannot eliminate in other settings. In order to get to global eradication, we would need high-level political commitment, really major increases in financing, which we will need. We will also need research, we'll need strengthening of health systems, and we'll need better malaria surveillance. It will be possible with a big ramp up with the tools that we have available to greatly reduce malaria deaths and cases from the levels they are now, and eliminate in many places, in the places where transmission is really very intense. And ultimately, to eradicate, we need to reduce transmission below one new case per every time there's a case. We need to ensure that there's less than one new case. In the real hotbeds of malaria transmission, we may need new tools together with the political will and financing to do that.
I was going to come round to that, actually, because that's an important part of the equation, isn't it? Is the effectiveness of the delivery system, i.e. how serious various, we're talking sub-Saharan African countries, how serious governments take the problem, and then how seriously they apply the advice and distribute the thousands of dollars or hundreds of thousands of dollars worth of aid and input that is made on this effort to try to control and contain malaria?
Well, there's a lot of positive movement in this area. We've seen major buy-in from many, at the political level, from many countries. There's a Southern African grouping which has made the commitment to move towards elimination with 8 countries in Southern Africa. In the Asia-Pacific, there is a goal to move towards elimination in the whole Asia-Pacific area. Major progress in many parts of South America. So there's really been a lot of progress. And in many parts of Africa where the elimination is not on the horizon in the next few years, the numbers of cases have gone down dramatically. In many places in East and Southern Africa, we've seen reductions of more than 75% of cases at the national level. And some of those reductions, let's remember, if you go back 10 years, 15 years, many people felt that was not going to be possible, and it has happened. People felt that we may not be able to get to high-level coverage with bed nets. In many places that has happened. It was felt that perhaps we wouldn't get to the high-level access with these really very effective artemisinin combination drugs. That has happened, so there's a lot of positive news.
OK, can I say now thank you to Dr. Vasi Morthy from the World Health Organization, joining us via Skype from Paros in Greece. And let's take this opportunity now to look at malaria's prevalence around the world. It was successfully eliminated from Europe, North America and the Caribbean in 1955 as part of a WHO initiative. But in 2013, around 100 countries were still having to deal with malaria cases and deaths. Around 9,000 of those cases were just east of the Mediterranean. They were actually in the Middle East. And 7% of the global malaria deaths were in Southeast Asia. But, as we've been saying, the majority of malaria cases are in sub-Saharan Africa, accounting for nearly 530,000 deaths in 2013. Right, we can now bring into our conversation Dr. Kweku Poku-Asante, who joins us via Skype from the Ghanaian capital, Accra. He's the head of research at Kintampo Health Research Centre. He's also the principal investigator of the RTSS malaria vaccine trial. Thank you very much for joining our conversation, Dr. Poku-Asante. Give us a an idea of the picture in Ghana today? How is the fight against malaria going?
Well, thank you very much. And I must say, I'm one of the principal investigators of the malaria vaccine trial that just got ended. So the situation in Ghana now, we still have a high burden of malaria. Mothers who go to the facilities when they are pregnant still have high levels of malaria parasitemia. Bed net usage, we expect it to be very high, but it's not as high as we would want to have it. So there's still a bit of a gap that we need to bridge. Okay,
and Dr. Riaz Malik here in the studio with me, it sounds very much from what we're hearing that it's going to take quite a bit of cash injection, really, to actually see this, this battle to the next stage.
Yeah, so I think it's easy to point the finger at despotic rulers of different countries, and I think it's more of a complex problem. It's kind of from, maybe there are some well-meaning rulers, but then it's delivery of an effective ITN or mass drug, administration on the ground. And you only have to go to these countries to realise, how broken the system is for the majority of ordinary people which malaria affects. And so, when you're scrabbling around for surviving, malaria actually, or using malarial nets, isn't a priority.
Dr. Poco Asante, I was particularly taken by the statistic that during the height of the Ebola crisis in the three most affected West African countries, Guinea, Liberia and Sierra Leone, that actually led to a massive increase in the number of deaths from malaria, indicating, I guess, the fragility of the recovery, because clearly the fight against malaria is working. The numbers are looking good. However, it was very easily set back by another crisis in the region.
Well, that's the problem in a system like this, where we don't have very strong structures, very strong health structures. We tend to easily lose it if there's a disruption. So that's exactly what happened in Sierra Leone and then also in Guinea.
And so this comes down to a question of governance, doesn't it, basically, and how seriously various governments are prepared to bolster their health systems and provide the basic care that everybody needs.
So yes, this is the key thing. Governance, good governance is good for all systems, health system, education, and every other thing. I would say that apart from good governance, we also need to work on things like health-seeking behavior from the individuals. So, for instance, if a child is ill and the mother herself does not know that the child is ill, that's a barrier to seeking health. If the mother does not have enough money to go to the hospital, to get onto a vehicle to get to the hospital, that is a barrier in itself. So all these things have various levels, and within the health system, yes, there's a role that the health facilities play. There's a role that individuals in the communities also play. It's a whole bag full of issues that needs to be dealt with, and governance is one of them.
And Professor Hill, Adrian Hill in Oxford, how far do you think is the attitude by the political leaders, both on a local and on a national level, in the affected countries? How much of a role do these attitudes play in effectively combating malaria?
Yes, well, appreciation of the huge importance of malaria right across sub-Saharan Africa is important. As Dr. Murthy said, there's been a lot of progress in getting political buy-in and recognition of the importance of greater funding for malaria control. We can now point to the achievements that greater funding over the last 5 or 10 years has produced. The risk, of course, is that after that improvement, that there's some donor fatigue, and people start concentrating on other things like Ebola, as you have mentioned. But we really need to keep the scale of malaria mortality in mind. 500,000 deaths 1 year after the next year after the next year is a huge mortality, particularly when those are in young children, compared to the total mortality in Ebola of just 10,000 cases, and now that has happily declined very substantially. So malaria is a problem, it's going to continue to be a problem, and we must maintain our efforts, or otherwise malaria will bounce back. And we know that that has happened in the past after a big effort, for example, in the 1950s and 1960s, when we thought momentarily we were winning against malaria. It shot right back up again once those efforts diminished.
And Dr. Riaz Malik, as we're here in Doha, give us an idea of the picture of malaria prevalence in this region, in the Gulf, and then more widely in the Middle East.
So it's actually very low. I mean, the whole kind of epidemiology of malaria is that you need water, stagnant water, you need somewhere for the Anopheles mosquito to kind of reside, and then you need populations that are prone to I guess the disease. So really it's not a major problem. Perhaps in areas where, for example, in Iraq, there may be issues.
Where there's disruption, huge disruption to services.
Or Yemen. So there may well be issues there that are beginning to arise, but really the prevalence is not huge in the Middle East.
But what we're hearing, it seems, is that this next stage in the campaign to beat malaria is going to require a huge tranche of funding, as well as the political will, of course. And we know that the Bill and Melinda Gates Foundation, they've already spent at least $2 billion. Where's this going to come from, and how do pharmaceutical companies prioritise the areas that they concentrate on?
If I want to be cynical, then I would say that we need, I don't know, malaria to take hold in southern Italy. Then you'll see a change in terms of how pharmaceutical companies will invest in this, or somebody important needs to be infected. And unfortunately, you know, until that happens, then I think there is a good political will in Africa. But again, as I said before, it's all about having the infrastructure, the correct infrastructure in place from the top down to the very bottom, which allows you to deliver effective treatment and effective preventative policies. So, you know, combating malaria isn't about a vaccine at the moment, or even the latest generation of drugs. It's about population-based changes in terms of eradicating the mosquito, or you know, changing health behaviours that will make a real change.
And so, Dr. Poku Asante, in Accra, with this vast amount of funding that's still required, and with systems needing to be in place for the effective delivery of all of the aids in terms of fighting the spread of malaria, it doesn't seem as though this is going to be happening anytime soon, certainly in sub-Saharan Africa, which of course is still crying out for these systems to be put in place, sustainable systems.
Yes, I agree with you. There's a huge gap that we need to fill up to ensure that we have a formidable health system that will be able to deliver anti-malaria drugs, that would also be able to deliver bed nets, produce and deliver bed nets to the people who need it most. Today we talked about the vaccine that we've tested, and if this is also found to be acceptable to the regulatory authorities, this could be one of the measures that could help reduce the burden of malaria. A vaccine, we've seen the impact of vaccines on diseases. I can talk about smallpox, and all these have been useful. But yes, it's a long way. As one of the panelists said, if this burden of malaria should be elsewhere in the world, we would have a strategic way now.
On that cynical note, thank you very much indeed, Dr. Kweku Poku Asante, talking to us live from the Ghanaian capital, Accra, from Professor Adrian Hill, talking to us from Oxford, and of course to Dr. Riaz Malik here in Doha with me. And thank you, of course, for joining us on this edition of Inside Story. Now, if you've got any thoughts, any questions, any comments, you can let us know. You can get in touch with us on our programme page at aljazeera.com. You can post your comments at facebook.com/AJ Inside Story, or you can always tweet us. Go to @AJ Inside Story. So from the whole team, it's bye for now.